time, what I'd like to do is let's go ahead and move to Dr. Muse, and then at the end we'll receive questions at that time that I'll address with the panel, if that's okay. Dr. Muse, same sort of question to you. Can you elaborate a little bit more about what Aetna is doing with regards to Hispanic health disparities and some of the initiatives that you've been leading and doing?
Sure. First, I would like to give a little overview of Aetna. Aetna is one of the nation's leading diversified healthcare benefits companies, serving approximately 36.3 million people with information and resources to help them make better informed decisions in their healthcare. Aetna has a long and rich history of commitment to social responsibility, as evidenced by our efforts to improve the quality of healthcare for everyone by helping to build healthy communities. In fact, in 2013, Aetna was named as one of America's most community-minded companies in the Civic 50. With the Aetna Foundation, Aetna in 2013 also awarded more than $20 million to nonprofit organizations across the United States. The foundation grants are focusing on improving nutrition, increasing physical activity, promoting equity in health and healthcare for chronic conditions, building a more diverse generation of healthcare professionals, and exploring innovative solutions to promote wellness and achieve health equity for low-income and minority communities. Our focus on diversity and inclusion reflects the world around us. Our workforce is very diverse. We have about 9% of Hispanic workforce, yet we are far off from representing the percentage of Hispanic in the community that we live, but we are way on the way there. Our vision is to build a healthier world, and to achieve it, we recognize we must realize the full potential of all the employees around the globe each and every day. Our mission is to promote wellness, health, and access to high-quality healthcare for everyone while supporting the communities that we serve. About 30% of our employees are people of color. 17% are in management and supervisory positions. 11% hold executive positions, and 70% of the board of directors are also people of color. 2% of our employees identify themselves as veterans, another 2% as gay, lesbian, bisexual, or transgender. Since 2003, cultural competency training was implemented for all of our clinical staff. We use quality interactions, cross-cultural training, and not only do we offer it for our clinical staff, we also offer the same information, the same training to all the doctors that are participating in the network or that have filed a claim with Aetna. In fact, we believe that cultural competency is important because cultural care is rapidly becoming a major quality of care issue in America. Several states require cultural competency for physician licensure, such as California, Connecticut, Ohio, New Jersey, and Washington State. And the program that we offer is recognized by those states and provide CME to the physicians that take it. Aetna has worked in collaboration with many different academic institutions. One program that is worth mentioning is begun in 2007 with the Columbia University in New York. The program was a medical integration where members with diabetes, hypertension, cardiac disease, or cardiovascular disease, or that were pregnant were enrolled in a program with enhanced dental benefits. They receive, without additional cost to them, additional preventive dental care. It was published, and remarkably, it showed that 3.5% required fewer hospital admissions in those that were participating within the program versus the ones that were not, were 5.4% more hospital admissions. In addition to that, they also had less major and basic services in about 42%. And the access to preventive care increased 10% for that population. Cultural competency for us is important. We believe that improving the healthcare outcomes for all the people that we serve, especially for underserved and vulnerable populations, will improve the outcome of their healthcare. In addition to that, Aetna has campaigns for the population, those that do not speak Spanish, and that do not speak English as a first language. We had the how to talk to your doctor. And over the years, we have been through the Aetna Foundation Communities Grant, supporting those different communities programs that are helping Hispanics and any other underserved population. I will entertain any questions that you may have.
Great, thank you, Dr. Muse. We have a couple of questions that have come in from our participating audience. I'd like to kind of share with them and see if each of you can answer them in your own way. The first question that has come across is this one. What can students in medical and public health schools do to possibly find a job at these major health insurance companies? David or Haiti, anyone want to take that one to start with?
That if you're in a good position right now to actually get hired, because right now we have a critical need for bilingual people or culturally competent people in the different roles. Now, we're a healthcare provider, although we have an insurance arm on this as well. But if you're either in a physician or a nurse or working in radiology or pharmacy, any of these disciplines here, there's a critical need for bilingual people to come into the workforce. So I think that it's actually to their right now when they go to apply for a position in whatever field they're in, that it's a good opportunity for them. If you're getting a master's degree in business administration or in public health or something like that, again, I think that the doors are going to be opening up for opportunities for people to go into this area because of the growing population we have and how we're going to service them. And so there's a critical need for people with this kind of expertise.
Thank you, David. And I would just echo that, especially a lot of academic medical centers now are realizing the importance of population health. Dr. Newhouse alluded to that with some of the mapping that they're doing. And so getting some, essentially some training regarding population health is probably going to be more important than ever. Dr. Muse, do you have anything to add to that?
In fact, there are many opportunities, not just within the clinical staff, but also non-clinical functions, customer service. We have a multilingual call center that is able to address over 300 languages. So medical directors, nurses, and non-clinical staff is really a prime, and we welcome those applicants.
Great, thank you, Dr. Muse. We'll move on to the second question, and this again applies to both of you as well. What resources or opportunities do health insurance companies provide for students that are interested in Latino Hispanic health outreach?
Well, Kaiser Permanente of programs for internship level, externship level, where people come in for various levels of time to work in the facility. As I said earlier, we're developing a pipeline to medical students where they actually come in, and depending on their level of training, they can go into the operating room, they go into the clinic setting, they shadow our physicians. And so, again, that's on the physician side, but the same thing where people are going into public health or things like that, there's opportunities to come in as an intern level, see what Kaiser's like, and I'm sure other healthcare organizations have the same programs, where they can see what it's like to how it actually happens at the workforce. And so, again, it's the training levels are at different levels depending on your background and how much time you have, but these programs are available.
David, if you could comment too, a lot of the students may not realize that Kaiser also provides residency program opportunities, that there are residents that are working in Kaiser with plans and future plans of staying with Kaiser, that they could also possibly be also be contacts for students that may be interested to find out what it's like. How do you apply to these residencies, and what's the difference in working in a Kaiser residency versus a non-Kaiser one?
A Kaiser residency versus a Kaiser residency? Non-Kaiser? You're on mute. I'm not hearing anything.
I'm not sure that there's general knowledge that residency programs exist within Kaiser. I was just seeing if you could comment a little bit on that.
Oh, sure. Yes, we have, and I'm speaking about Northern California Kaiser now, but we actually have 3 hospitals where there's residency programs, San Francisco, Oakland, and Santa Clara. And the process for applying is like any other medical student, you know, in the country. So where there's a place where you go online and you apply for these residency and internship positions. It has become very competitive across the country, though, for residencies, because what's happened for the first time last year was that there's actually more applicants for residency programs or actually openings in the country. It's starting to lead to some issues, not just across the country for these students applying, but the residency programs are in primary care, OBGYN, pediatrics, and medicine.
Dr. Muse, same question to you. Is Aetna doing anything right now and providing any types of opportunities for students that are interested in Latino health outreach and working with Aetna and any of the associated hospitals or companies around that?
Absolutely, yes. We have a long-standing internship program. Most of the time, summer interns, but we also hold work health at different colleges and work very closely across the country with universities and colleges to recruit students. Most of those positions may not necessarily be within the clinical staff, because medical directors and nurses, they have to be already graduated with some history about work. But the opportunities are vast across all areas in Aetna. And all the information of how to apply is all on the website, aetna.com.
Great. Thank you, Dr. Muse. Another question for you. What are the top 2 to 3 priorities that Kaiser Permanente and Aetna have with regards to addressing Hispanic health?
Oh, top 3 priorities. I think one of the priorities we have right now is that our membership is growing under the Affordable Care Act, and that, as we already know, that we have a gap in our healthcare metrics between Latinos and whites. And if we don't close our gaps in our metrics, as far as making sure that we have just as good a diabetic control, hypertension control, colorectal screening, mammogram rates as our white patients, we're going to have a problem here. Because first of all, it's the ethical thing to do. We want to provide top-notch care. But second of all, if you have deficiencies in how you provide your care, then it's not going to be very cost effective either. And as we know, as we go forward under the Affordable Care Act, that reimbursement rates are dropping, so it becomes critical not only from an ethical standpoint of providing top care, but also from a financial standpoint. Having a higher readmission rates for patients is not a good thing to have happening. So I think it's going to be how do we continue to improve the healthcare outcomes for our Latino patients? How do we make sure we're providing the care they expect, making sure that we have our service standards are good whether you speak English or not, and also keeping it affordable. A lot of our patients right now, not just Latinos, are having trouble, with healthcare costs. The co-payments are going up. So how do we also maintain that we have a healthcare program that also is affordable for our patients? So I would say it's quality service and controlling healthcare costs going to be the three top priorities that I would see.
Thank you, David. Dr. Musse, what about for Aetna? What are the top 2 to 3 priorities in addressing Hispanic health as Aetna talking about and thinking about to move forward?
We are collaborating with doctors, hospitals, pharmacies, labs, and other healthcare allied providers to build a simpler and more integrated healthcare system. We are focusing on incentives, on reimbursement to the doctors. We have been identifying whether there are different languages that the doctors' offices are available to provide to our members. We publish that information on the website and the not only for the doctors, but we also have programs. We have been collecting voluntary demographic and ethnic information for our members. The recruitment of providers or vendors that we work with is always taking into consideration the diverse population that we are servicing. So it's not just the Hispanic community. We have other similar initiatives to try to provide information, the languages that they use, with doctors and healthcare providers that are sensitive to cultural issues that the population that we service encounters.
Thank you, Dr. Musse. The next question that people have for both of you is, what does success look like for KP and Aetna with regards to Hispanic care delivery? In other words, where does, with all the programs and initiatives and interests that you have in place, where do you see yourselves in 5 years, and how would you define success in knowing that you're there?
And any success for me anyway would be that we close the gaps in our quality metrics, our service metrics, that we make sure that we're providing the care they need. But even if we were to close the gap, there's still room for improvement in all of our population groups. And so, for an example, it's not just race and ethnicity, for example, but we see that we have gaps between gender and also between age groups. And so as our pediatric patients tend to transition out of pediatrics, we find that oftentimes their satisfaction, for example, when they transition to their medical primary care doctors is not as good as it should be, whereas our older patients tend to be very satisfied with their health care. We also find there's gaps by gender. So, for example, that when we looked at hypertension, say, between whites and blacks, we actually found that the black men actually did better than white women. So again, it's keep breaking down the data further and further. We want to keep subsetting to where we keep finding those different groups that we have gaps in. I think in 5 years, if we get to the point where we've pretty much closed all the gaps with all the different groups that we take care of, that would be a sign of success. I'm not sure 5 years is going to be enough time, but we are making improvement. When we look at our statistics, we see that we are improving in all the areas. But is the rate going to be fast enough? We have an obesity epidemic in this country, for example, and the number of diabetics coming in is rapidly growing. And so it's doing that root cause analysis. How do you get into the community to make sure that they have access to good food, not just junk food? How do we make sure people have transportation so they can get to see their doctor, or do we do outreach programs in their community? It's going to take a multifactorial, multidisciplinary approach as we solve these problems. Some of it's going to involve government, some of it's going to involve academia, some of it's going to probably working with other healthcare companies. I think we're on a good track, but we still have a ways to go.
Certainly what you're bringing up is an important point, is how can we collectively partner in essentially trying to at least reduce or alleviate some of the social determinants of health that really affect us from the proper delivery of care. Dr. Musa, how would you answer that question with regards to success and where Aetna hopes to be in 5 years? How would they define success with some of the initiatives that you've been involved in and leading?
But our vision is to build a healthier world. So we want that our members and the population gets the right care at the right time, and that the care, the cost of the care is affordable. So if we are able to achieve that, that would be the ideal. Whether we are able to accomplish that in 5 years, I'm not sure that it will be in 5 years, but we are on the path to get there. All of the programs that Aetna is involved in are really addressing the diverse communities that we have. Through the Aetna Foundation grants, again, we are going into the communities and supporting those programs that are addressing health and physical activity.
Thank you, Dr. Musa. The next question has to do with each of you describing with the initiatives to improve Hispanic health for the populations you serve. What have been the greatest barriers and challenges that both of your organizations have faced in getting buy-in from and also from the in this? Dr. Musa, let's go ahead and start with you first.
We couldn't hear you.
Sorry, let me repeat that again. Considering the initiatives that you have in place in addressing Hispanic health, what have been the greatest barriers and challenges with getting buy-in from the administration, but also from the staff, including physicians, to essentially move forward with this initiative to improve Hispanic health? What have been your greatest challenges, and what can we learn from you in getting maybe our own administration and staff buy-in that this is important?
Have been the population itself, their own cultural belief about healthcare and prevention, and some of the physicians not able to really reach out to those members. We've had a few pilots to provide information specifically with the Hispanic community. It was a major hotel corporation where we provided the information in Spanish, we provided case managers and pretty much on-site assistance. And with the information, we were able to improve the prevention, screening preventive tests that they needed, and overall the healthcare for those members. I think the major barrier is how the public, the Hispanic community, is the lack of trust in the healthcare. And that's something that we have a lot of work to do as a society.
Thank you, Dr. Musa. Dr. Newhouse, are you still there?
The biggest barrier that I saw over the years was there was this resistance to even collect data. There was a resistance to understanding that there was this growing population that were going to be having to take care of, especially as they grew in numbers. There was a resistance to having interpreter services. There was a lot of resistance because they were afraid it was more costly. The doctors were resistant because they said, well, it takes more time to take care of a non-English speaking patient. There was a lot of issues around our staff and how to handle patients who didn't want to speak English. We had sensitivity issues there. So it was a multi-year project where we really had to, first of all, get buy-in from our leadership to say this is something we have to take on, and they are there now. But it takes time to get it down to the rank and file. We have a program where we give every doctor their service scores. We give them their quality metrics. We show them how well they do with different groups. But it takes time to get the data collection programs necessary to do this kind of work. We've done work around creating modules for Spanish-speaking patients, but these are helpful, but they're not the whole answer because you can't send all the patients to a module. There are subspecialty clinics, for example. So again, making sure we have a robust interpreter service to take care of the patients at every point along their care. We established a strong Latino association too for our staff and physicians to join. Again, promoting the need that we need to recognize our Latino staff and physicians as well. So I think those are some of the resistance we have, but I think as we've come a long ways in overcoming that resistance, but it held us back for a long time, to be quite honest. I think the data is there now that if you were to go to your leadership, I think the case is pretty clear now of what the need is there now, but it wasn't so clear 10 years ago.
Great, thank you. The next question is really about academia, and it goes, how can academia work better with healthcare companies like Kaiser and Aetna? Dr. Mousse, would you like to start on that one?
Sure. Actually, our leadership very early on we didn't have to convince them. They pretty much believe in cultural diversity and addressing the issues that we have been discussing. Back in 2000, 2001, Dr. Jack Crow became CEO of Aetna, and indeed, he brought with him his medical knowledge and transformed the culture of the company. So we have been working with academic institutions, developing programs not just for Hispanic but other diverse populations we serve. And we continue to do that. And as I mentioned before, through the Aetna Foundation, there have been, it's about $100 million that the Aetna Foundation have provided grants over the past decade. And all of those grants are pretty much focusing on health equality issues.
Dr. Mousse, the next question's about how has Aetna worked with, is there any examples that you can talk about with regards how Aetna has worked specifically with any academic medical institutions, medical schools, nursing schools, public health schools?
Well, the program that I mentioned, the dental medical integration with Columbia University, it wasn't necessarily just with the Hispanic, but it was a diverse population. Most of them were really Hispanic.
Okay.
That's just one of the examples.
Okay. Dr. Newhouse, you talked a little bit about the residency programs that Kaiser has. Is there any collaboration with any other academic institutions outside of Kaiser that you've collaborated with and partnered with?
Collaboration going on. We've worked with Stanford, UCSF, Davis. I think we've also got our division of research is starting to do more work with institutions such as Mass General, Georgetown, Harvard. Again, the problem is bigger than healthcare, and so we need to start partnering with academia, with other groups as well. If you want to do a research project, a large number of patients, again, you're going to have to collaborate with other healthcare organizations to have centers where you can get enough patients to take a look at, to get the data you need to really understand what's going on. So more and more, you're starting to see more collaboration taking place between academia and Kaiser Permanente in our division of research, between our residency programs. We've had Stanford students come here. We have programs where we can send people around. So,
thank you. Dr. Newhouse, this question is for you specifically. The question is, can Kaiser provide some ethnicity statistics in regards to the residents that they're accepting at their programs?
I would have to check with the director of the program. I would like to say they can. I think medical students report that now, but I don't want to 100% say that, but I would say they probably do. What they are right now, I couldn't tell you, though.
Thank you. The next question has to do with specific strategic plans, and the question is, does Kaiser and Aetna have a strategic plan specifically addressing the Hispanic health disparities? I think you covered it in some ways, but I think the question is specifically, have you created a strategic plan for that? And could you share some of the highlights of that?
Oops.
It's not just Hispanic, but rather it's the overall diverse population that we service. We have a global presence, so we have many different ethnicities, and it's not just ethnicity, it's also multi-generational. So the issue is really broader in nature. The strategy is really encompassing all those different elements, not just the Hispanic.
Dr. Newhouse?
Yes, right now we've embarked on a very aggressive program for our Latino population here in Kaiser Permanente, where we're doing a lot of outreach into the community, having clinics at the churches, doing outreach with different organizations. But it's not just the Latino population for us either. We're also looking at our Asian population, immigrant populations. I know where I work here, we have one of the largest Afghan populations outside of Afghanistan. So we've done a lot of work around refugee populations as well, which are in very impoverished groups. So it's not just one group, but we're looking at all the groups, and it breaks out by different facilities. So if you go to San Francisco, it's largely Chinese. If you go to Oakland, it's mostly African American. If you go out in the Central Valley, it's mostly Latino. So we take these things into account too. We try to customize at the medical center as well that's going to interface with the groups that are dominant in that area. But as far as the Latino population goes, it has become a very strategic group for us to work with, both in outreaching to our patients, to the new members that come on, and also making sure that we have the staff and physicians necessary to handle the population as they come in.
Thank you. Thank you very much, both of you. So, we're at that time in the hour. No more questions look like they're coming in. Maybe just give one more minute for anybody to submit any further questions before we close the session. I do want to thank you too for taking the time to address, I think, what is a very important topic and a very interesting topic that everybody is concerned with, and addressing in the best way that they can, given the rapidly changing demographics. And certainly I know, living in California myself, as we have become a majority minority state, ultimately those are a minority majority state, essentially we know that that's one of the top priorities that we're addressing as well too. So I thank you both for the work that you're doing, for keeping Latino health on your radar, and to put some successful initiatives through. And hopefully what we can do is that we can basically begin looking at some of your initiatives and programs as you achieve your successful outcomes from that. Would be wonderful to see this, wonderful to see almost any particular types of publications of your successes of this, so that it could possibly be used as future models for us to look at as well. So with that, just going to offer you two any last minute statements from either of you.
Well, I just want to thank you for the opportunity to be a part of this, and as I think we go forward, it might be nice to reconvene in the future to where we can start to show some of the more specific projects that people might be interested in.
That's a great idea.
I just want to thank you for giving us the opportunity to present some of the programs that we have, and in the future we hope to work even closer with your organization. Thank you.
Great. So thank you, Dr. Newhouse. Thank you, Dr. Muse, as well. And I want to thank all of our listeners and folks that have participated in our third and final webinar series. And on behalf of Hispanic-Serving Health Professional Schools, again, thank you for attending. And we're always very open to any suggested topics for the future that we can address. With that, I'll say good afternoon to you all.